What's up, you guys? I am finally back.
Fly so high, I'm hypnotized. What's up is down, what's left is right.
For those of you guys that are new to my channel, my name is Morgan. I am a second-year medical student in New York City, but because of the weirdness of my medical school's curriculum, I am 75% done with my clerkship year or my core rotation year. And for those of you guys that are already subscribers, thank you so much for your patience, because it's been forever since I shared a video. And the reason for that is because your girl has been in the trenches of busyness. So I just finished my medicine rotation, which was 10 weeks. So I feel like that just took up so much of my time because I really want to make sure that I was like doing well in the rotation, and I was really interested in it, and it was like so busy. And then also like we are in the midst of the craziness of the 2024-2025 application cycle. So I've been doing a lot with helping students as they're preparing their application materials, reviewing my application materials, and then making sure that my course from applicant to accepted is fully set up. And then you guys know I also recently launched the PREMED planner journal, and then I've also been doing a lot of traveling. So I've just been so busy, but I'm so excited to be back, and excited to be back with this video, which is another rotation recap for my medicine rotation. So it's going to be the same layout as all the other videos. I'm really hoping that, for one, these are just like a way to document like my life and my experience on clerkship year. It's also to give you guys an idea of what like rotations look like for medical students, and then it's to give you guys like tips and advice so that way when you get to your clerkship year, you will have a foundation of like what you can do to succeed. So we're gonna start a little bit like just talking about what my rotation schedule looks like. So my medical school does not have a family medicine department, so we don't do a family medicine like core rotation. Instead, we just have a medicine rotation, which is 10 weeks long. And part of that is 6 to 7 weeks of inpatient medicine, and then we have 3 to 4 weeks of ambulatory care, which is outpatient medicine. And most of the time that's working with internal medicine physicians or specialists like cardiologists, nephrologists, different things like that. But I wanted to do something a little bit different, so I decided to work at the NYU Undergraduate Student Health Center, and so I was mostly working with family physicians, which was amazing because I'm interested in family medicine, and so I just got to see like a broad array of everything. So that was my first 4 weeks, and that was more of a traditional 9 to 5. So yeah, so I would like usually get in there like 8:30, and I would pre-chart to see what patients I was going to see for the day. And I was working with different doctors. Like each morning I was working with a different doctor compared to the afternoon. So I was able to work with like so many different physicians and see their different styles. And they would usually let me see patients that I felt comfortable with. I would go in and like see the patient on my own to get like the full history, do all the physical exam except for like any intimate exam, and then I would go out, present to the physician, and then we'd go back in and see the patient together, and then they would put in the orders. I would finish the note, and then that would be kind of how it went for the day, and then I would get out about 5. So that was really cool. I got to see like just a little bit of everything. I think everybody thought they were gonna be like, you're just gonna see like STDs and STIs, but I actually got to see like some genetic disorders. I actually worked with a PM&R doctor, and so I saw a little bit of back pain. There were some older patients, so I got to see chronic conditions. It was just like a little bit of everything, so I really loved that. And so that was like, oh my god, I really love outpatient like primary care, and I also really love like adolescent young adults. So that was really cool because I feel like it was the first time I really got to work with that patient population. Then I did my 6 weeks of internal medicine. So we are split at 2 sites. So the first site that I worked at was Bellevue, which is the public hospital, the oldest public hospital in the country. And so once again, like majority of the patients don't speak English. Most of the patients are uninsured or underinsured. So it's just a really unique like patient population. You really get to feel like you're making an impact. That was where I got to do my first like, for that we do 1 weekend shift at each site. So I did 1 weekend shift or 1 weekend day at Bellevue, and that was really cool because most of the admissions are done with the overnight resident, but my like resident made sure that they saved an admission for me, so I got to do like a full admission for a patient by myself. So that was literally like, you have their chief complaint and like you can look at their chart, but other than that, like there's no orders put in for them, there's no plan, and so it's really like up to me to kind of like figure that out on my own. And it was really cool, and I've really learned a lot and really got to like build a great relationship with that patient that I got to admit. Really like took autonomy for that patient, so that was great. And then the schedule for that was more like, I got there at like 7:30, then I would see patients either with my intern or by myself. Then we'd do team rounds at around 11 to 12. We had noon conference every day. That was my favorite part because we got free food for 6 to 7 weeks, which was amazing because we don't get like a food stipend or anything at my school for rotation, so it was really nice to get free food every day. And then in the afternoons we would either have different like teaching sessions, or we'd go back to our team and do like afternoon running the list, different things like that. And then some days it's just depending, like I would get out like 3:30, other days it'd be closer to like 5. So it was really good. And then I did my last 3 weeks at the VA, which is very important to me. Like my mom is a veteran, I have other family members that are veterans. My mom actually has spent some time at the VA, and so I thought it was something that was really unique. Also just like another very unique patient population that comes with like their own, like, I don't know how to say, like it's just a unique patient population. There's like a lot of like mental health, PTSD, there's a lot of, you know, exposures from things from when people were like abroad and in different wars that you won't really see at like a private or a public hospital unless you're also working with veterans there. And then also just like being in a place where we could just like take a patient downstairs because they had like an outpatient appointment at the VA and like coordinate everything there, and everything's just like covered, especially if they're service connected, different things like that. I thought that was really interesting to see that model of healthcare, and then just to take care of that patient population as well. And that was similar, like getting there around 7:30, and then their patient population is less. Like my team had 20 patients when I was at Bellevue, and then maybe like max of like 13, 15, but usually less when I was at the VA, so I was getting out closer to like 3:30. So that was really nice. So that's what my schedule looked like, and really lucky that my school only makes us do like 1 weekend day at every site, so I was not working like 6 days a week, so had a lot of time to still like rest and like study for the shelf exam. So that was what my rotation schedule looked like. You guys have probably like can tell from the way that I'm already like starting off this video, but how the rotation went, I think that it went like amazing. I loved my medicine rotation. AmCare was amazing. I think like just being able to finally work with like family physicians, because my school doesn't have a family medicine department, like haven't been able to like really like build those relationships and get like great mentors, and so that was really cool, like just getting advice from them on like what electives I should do, what conferences I should go to, different things like that. And then when I was at Bellevue, I had such an amazing resident. Like she really just wanted to make sure that like we were shown off, I feel like, to like the attendings, and that we were able to like demonstrate our knowledge. So like for complex patients, she would do many chalk talks for us, so just like super quick, like, okay, if someone comes in hyponatremic, what are the first things that you check, and then how do you work that up? If someone comes in with anemia, how do you work that up? What is going to be like the main safe treatment for congestive heart failure, different things like that. And so I feel like I was just like so able to learn. She literally went through like EKGs and like where the leads go and like how that translates to what EKGs look like on the paper, how you can do like posterior EKGs, like all that. It was honestly amazing. And so I felt like I had a great experience too, because like she pushed us outside of our comfort zone, but she also really like nurtured and helped us to learn. I've already like kind of alluded to this, but like the patient that I got to admit, I admitted her on like the first Saturday of my rotation, admitted the patient on the first Saturday of my rotation, and then was able to discharge them on the last day of my rotation. So I feel like just really seeing like the evolution of the patient, getting better, getting healthier, and then having the time to like dedicate to, like, I saw them every day for 2 weeks and doing patient education and really building those relationships and advocating for them. So I thought that was really cool. Something that like one of the main reasons I wanted to do family medicine is because like the longitudinal relationships with patients, and I felt like you couldn't get that in a hospital setting, but I realized that you actually can. So it was really cool, really special. And then also like realizing that I'm learning things. I think with clerkship year, you're just like boom, you go to neuro, and then you go to psych, and then you go to surgery, and like every rotation, every specialty, they have like niche acronyms they use and niche tests they do and things like that. But medicine is really like the culmination of everything. And so I remember sitting, like, I think it was the 7th week of my rotation, and I just like sat through rounds, and I was like, wait, I didn't have to pull out my phone to like quickly Google what an acronym meant or like what they were talking about. I just like not like fully understood. Like, I'm still not like a resident level or like an attending level, but I feel like for my level of learning of being a medical student, I was able to sit there and fully understand like what was happening when they were talking about patients during rounds. And I thought that was really special and really just like a time for me to reflect and see how much I have learned since I started Clerkship here. So that was amazing. So now we're gonna get into the nitty gritty, what you guys are probably waiting for, which is like how I studied for the shelf exam. So I will say that I didn't do as good on the shelf as I would have liked. So I got a 71 on the shelf exam, which is like fine because like at my school, like we don't prioritize the shelf exam, I think, as much as others because it's only 10% of our grade, and like the passing score is like a 56 or something like that. So, and when you get like the shelf score report like back, I think the average was like 74, and so I was within like the standard deviation, but like still wasn't like my best shelf score exam. And so I think I probably understand like why that happened. I was definitely slacking off on studying. Like, this rotation was so long, and also there was so much to study. So there was 2,275 Anki cards, and once again this was going through the Anking deck and then doing shelf exams, doing internal medicine, no dupes, and then only step 2 cards. So that was so many cards. So I was doing like 75 or 50 Anki cards per day. And then there was also 1,121 U-World questions. And I think towards the end of the rotation, like that would have been like doing like 25 to 30 U-World questions a day, which just wasn't sustainable with like the OSCE, all of the like assignments, patient presentations, and other like oral presentations I had to do during the rotation. So I really just like slacked off, and this was the first rotation that I didn't finish all of the U-World. And so I think that definitely showed on my like ultimately on my shelf score. And then this is kind of like a hot take, but this was the first time that I did 4 like practice exams. So the NBME has practice exams, and so for internal medicine there's 5, 6, 7, and 8, like those forms are available. And I think they were like, I think I also like got very relaxed because like I did really well on those. Like I was getting like 80%, and so I think though it definitely like overestimated my score, those practice exams. So yeah, usually I do like 1 or 2 practice exams. So I think in the future I'm gonna kind of go back to like making sure I finish U-World and then doing like 1 or 2 practice exams rather than like focusing on doing more of the NBMEs, which I know like most people would disagree with. They're like, make sure you do as many NBMEs as possible. But like from my experience, for the other shelf exams, I've gotten like at average or above average, and I've focused more on U-World. So I think that's what I'm gonna go back to doing. I do think that the Dr. High Yield internal medicine video, I'll link that below. It's like 3 hours long, so definitely pace yourself. Watch it multiple times if you have a chance. Very helpful. And also the Emma Holiday videos. It's a lot of like Emma Holiday videos, a lot of like the content in there. I think it's like 2 hours, but then there's also like the PowerPoint slides, which she doesn't get through in the 2-hour video. So probably again like dedicate like 3 hours to. If you do Anki, then like a lot of the information in the Emma Holiday video is in the Anki cards as well. But I think it's just like a nice review to do like the week of the shelf exam. And now, tips for the internal medicine rotation. So I think the main thing for me was learning how to broaden my differential. So when someone comes in with like chest pain, you're like, okay, heart attack. And once again, like you're gonna want to like rule out, you know, like STEMI and STEMI, but also, or like any of the like acute coronary syndromes, also like realize like they probably started to like rule out a lot of that in the ED, because that's literally the ED's goal is like, is someone dying or not, and is there an intervention that we need to do? So like when they come to you kind of admitted, you know, you probably already got like the EKG, the chest x-ray, things like that. So definitely think of, you know, could it not like to downplay it, but like, you know, if it's tender to palpation, then okay, maybe it's like a muscle strain, maybe they could be having a PE, maybe it could be pneumonia, maybe it could even be like GERD. So just thinking about like considering different organ systems and not saying, oh, chest pain has to be something related to the heart, just keeping your differential broad, in which like I think you learn how to do with just like more patient exposure. But one of the things that I always like to do was whenever I would give like the differential diagnoses is try not to look at the note, like the plan in the note before you come up with like what you think the patient has, and then even if you like brainstorm after that, just like ask your resident or your intern or your attending and just be like, hey, is there anything else that like you would have included on your differential diagnosis, or how would you have prioritized your differential differently than mine, just to kind of see like how someone who has more experience than you would think about a patient and their presentation. Next, up to date is going to be your best friend. Hopefully your school gives you access to update. Absolutely love it. I feel like there's just so many changes in terms of, you know, like what is goal-directed medical therapy for different things like heart failure, chronic kidney disease. Also, you know, like if your patient has chronic kidney disease and you have to alter the medication dosage for alter medication dosage if they're renally excreted, different things like that. UpToDate is amazing. And I also realized that UpToDate has a like these like patient education handouts that you can print off for your patient, and they have them that are like at 5th grade reading level, and then they have some that are like at higher reading levels. So I think that's really helpful. Like I had a patient that had orthostatic hypotension, and so I explained it to them, but like that's a lot just like here and like, oh, what are the different things that you need to do? And so I was able to just like give them that handout, walk through it with them, like highlight the important things just so they would have that to take home as well. And you can just like print those off for free if you have the subscription. Next, get very familiar with SOAP style presentation. So subjective, objective, assessment, plan. Like this is going to be like the mainstay of your life. I feel like on my other rotations, it was very like directed, like for psych, where like, okay, what is their like psychiatric illness that we're covering, and like how do we treat that, versus like medicine, you're kind of like the middle of the circle, like the target, and then like you're everybody else like that you're consulting, you're still like responsible for like integrating. Like we would consult renal, and whatever renal wanted us to do, like we were still responsible for putting in those orders. So just become very comfortable with doing that. Like ask your resident and your attending, like for new patients, of course, you want to get like the full like HPI past medical history, but then like when you're running the list or doing rounds, like do they want just the updated plan? Do they still want you to give the one-liner in the plan? How do they want you to do that? And then in terms of like the plan part of the note, do they want you to do systems based? Okay, what's cardio, what's renal, what's like fluid, electrolytes, nutrition, or like what's all the different problems? So okay, they have heart failure, they have diabetes, now they have like acute exacerbation of their COPD. Do you want them to like present like that? Most of the time we did problem-based presentations, but you never know, so just always ask. Call consults, like just call consults. If you need to like consult a service for your patient, just be like, hey, do you mind if I do that? Or do you mind just like being close by while I try to call this consult? Or how would you recommend calling this? Different things like that. With every consult service, they're going to want something different. Like, do they want the patient ID number first, or do they want to know the chief complaint, or different things like that? But I think just becoming more comfortable with making those calls, you'll become more comfortable with, you'll just become more comfortable with it. And also I think it like really helps to hear like the consulting physicians, to hear what they have to say about your patient and just to become more involved in their care. Also, you want to know different like details, like for if you're going to say your patient has CKD, you want to know what stage CKD they have. If they have heart failure, you want to know the most recent ejection fraction. You want to know if it's diastolic or systolic heart failure. You want to know if it's what's the word? I just had a week of vacation, guys, so like my brain is off. You want to know if it's ischemic versus non-ischemic, and you also want to know like the mainstay of treatment. So usually like a beta blocker, an Entresto, spironolactone, empagliflozin was kind of like goal-directed medical therapy, because like when you're calling cardiology for someone that's heart failure, you're gonna be like, are they on GDMT, goal-directed medical therapy? So you want to be able to know that. For diabetes, you want to know their most recent A1C. And then like for anemia, you want to know like the different classifications. You want to know, okay, if they come back with like a microcytic anemia, I want to send iron studies. If they come back with normocytic, I want to send reticulocyte count. If they come back with like macrocytic, you're going to be thinking more like B12, folate, that vibe. And then like COPD versus asthma, distinguishing those. Make sure you know how to read like EKGs and chest x-rays. And as a medical student, you just like, okay, yeah, like if you see like a big cavity on a chest x-ray, you want to be able to identify that, but you also want to have like a way to do it. Like a systemic way to read them so you don't miss things. So like EKGs, like rate, rhythm, axis, intervals, and then anything else that you're seeing, like bundle branches, U waves, different things like that. And then for chest x-rays, I did like the ABCDE method. I continue to forget this, but like airway, so like is a trachea midline, and then you want to do bones, make sure there's no fractures, and then you want to do cardiac silhouette, so like is it half the size, just to see like if the size is right, is there like cardiomegaly, diaphragm, can you see like the costophrenic angles, and then everything else. And then always do physical exam on patient skin. I feel like it's so easy now that like we have so much advanced imaging, like POCUS and different things like that, that we're getting away from doing like physical exams on patients. But still, like, I think this was the first time that I really was able to see like, okay, I actually know what, I can't tell you exactly if this is like an S3, S4, or like diastolic heart murmur, but I do know that it's not a normal heart sound. So just being able to like distinguish that, and you can just like hear so much better when you're on the patient's skin compared to like doing it on top of their clothes. And especially if someone's observing you, always do it on the patient's skin. And then 2 good apps to get. MD Calc is great. It helps you like calculate different things like Chad's VAS score, just like anything that you might need to do, like calculate patients' risk for different things, like the Wells score for PE. That's like a free app that you can download. And then Clinical Problem Solvers, this is a paid app, but I think it's really nice. It just has like good flow sheets for like cheap complaints, differential diagnoses, and different things like that. So it was a really good investment. I know I just threw a lot at you guys, but this was a 10-week rotation. Used to be 12 weeks, but with our condensed curriculum, it's now 10 weeks. So I learned so much. I had to get through so much, and I'm so excited that I was finally able to get back on here. So excited to get this video put out for you guys and to hopefully get back to making videos more consistently. So if you want to see more videos, make sure to drop in the comments below what you like, what you want to see more of, and make sure to subscribe so you don't miss out when I share new videos. Take care, you guys. I'll see you next time.
Fly so high, I'm hypnotized. What's up is down, what's left is right.